So happy and so grateful for this opportunity to share some of our learnings and our journey in training community health workers in primary eye care. So all of you did answer, and I think all your answers were correct and relevant. And yeah, so it's important to know what we mean by community health workers and what we mean by primary eye care. And we will go through that. Essentially, currently, so how the way I'm going to go about it is one, we'll just in the beginning just discuss the relevance of this cadre of health professionals, their relevance in eye care, their relevance to us as eye care professionals, and the relevance in us, engaging with them and training them. Then I will be talking about the teaching learning journey, and also some at the end with certain concepts and challenges and learnings which we had through this program. To come to the questions, all of you have already answered this, and actually there is a whole lot of people say confusion around this term, but I think it's a good confusion because a community health worker or a primary health worker, some people call them frontline workers or grassroots workers, are very context specific. You cannot put them into a single definition because each and every context, even in a single country, is so different. So it's a good to have an umbrella kind of a definition, which is they are lay people, firstly, who work in their own communities, and their role could be anything. It could be promotion, prevention, screening, referral, or even healthcare delivery. So, for example, in Africa, community health workers have been trained to do trichiasis surgery. That is because they have such a paucity of healthcare professionals, and so therefore, their roles and responsibilities depend upon the context. So it's good to remember that. And when we engage with them, then we can define what a community health worker means to us depending on our context. Similarly, primary eye care itself has several connotations. Similarly, in some countries, it's mainly promotion and prevention and screening, and that is what we do mainly in India. But again, in other countries, it could also have a health delivery or a medical delivery role. So going on from there, coming to the relevance, how many of you have heard of this term, integrated people-centered eye care? Maybe we could just see hands in your emoji screen, just to know how many people have heard of this term IPEC. Yeah, so a lot of great. So now coming towards integrated people-centered eye care, this is the buzzword, one of the buzzwords for 2030 Insight strategy, and it is part of the integrate pillar. So integration in IPEC has two connotations. One is you integrate primary, secondary, tertiary eye care, which is the vertical integration. But when you're talking about horizontal integration, that means eye care getting integrated horizontally into primary health care. And that is why it is important. Now, my whole talk is going to be about how we actually integrated eye care, primary eye care, into primary health care. So the community health workers that I will be speaking to you about are actually general healthcare workers. These are community health workers who provide general primary health care. And this is an example of a horizontal integration with the existing healthcare systems. And I've just put these little symbols just to say that it's very important. Primary community health workers play an important role in integrating at so many levels, between communities and schools and primary eye care, between primary eye care and primary health care, between primary and secondary, as well as rehabilitation services. So because they have such a great role, and they are integrated within communities. Like some people had said, one of the response, they have a problem communicating with the community, or sometimes the patient response is not good. Integrating with using these health workers who are actually community members really goes a long way. So next, coming to competency-based approach. How many of you have heard of this? I'm sure a lot of you are alumna from IXL, and some of you are trainers. A lot of ophthalmologists I see, and I know Aura curriculum is now going towards competency. But just to see a few thumbs up as to how is everyone familiar with this approach of the competency-based approach? Yeah, great. Yeah, so just before we go into the description of the program, a competency by itself is an observable ability or a skill of a health professional, and it integrates multiple components such as knowledge, skills, values, and attitudes. Now, when you plan a competency-based approach or a curriculum, you first start off with the original curriculum, the older ones, which are not competency-based. You start off with your theory, or what this is what I want my learner to know. But here we are looking at how does my learner look like? So so a finished product. When my learner finishes this training, what are the abilities will they have? So you start with that, which is the outcome-based approach. You identify the abilities, you define the competencies, and you actually first look at the assessments, like what are my assessments, or is going to be my evidence that my learners have actually become competent. Then you look at the educational activities and the instructional methods. And finally, you also need to look at an outcome evaluation to actually have a full competency-based approach. If anyone has any questions at this moment, would you think? Otherwise, I will keep going. Um, just 1 minute. I think I seem to have lost my slide. Um,
We are seeing your slide, so.
yeah, okay, yeah, okay. Um, yeah, sorry.
No.
Yeah, it's visible, right? Yeah, sure. So, is my slide moving?
We're still on the competency-based approach.
Oh, yeah, it's moved now. Yeah, it's moved, right? Yeah. Can you see the next slide now? I think there was
Yes.
yeah, sure. Yeah. So, so I'm just going to give you a walk through now towards how we develop this competency-based approach. And specifically for this cadre of health professionals, one of the main points I want to leave behind is that we need to start with the context. If you also read other literature around development of the curriculum, it's very important that there's a word called milieu, which you look at, the environment or where the training will occur, or environment where your learners will go back to. And that is extremely important for us to consider even before we start looking at the competencies, because those competencies have to work in that environment. So just to give you an overview, that I work in a tertiary care teaching hospital, which is actually a general hospital. So it has got many specialities. We are not a standalone eye hospital. And we, as the community ophthalmology unit, we work with all our community health areas. So we have some 5 to 6 areas which are run by either community health doctors or community health nurses, and they have their own teams, of which their own community health workers are a part. These are different areas. They are urban slums, tribal areas in the mountains, or rural or semi-urban areas. And they already have teams which are looking after other healthcare, and their community health workers who work in those areas are the ones that we engaged with. Now, also looking at the different areas, even the health workers themselves are very different. So just to tell you this background, so some areas have community health workers who they have employed, who've been with them for years, and they are salaried. They have another area where you have health workers who get paid. So if there is a project, say we have a RAB project or something else, some other project where, you want them to work, then they get paid by the amount of work they do. Then some areas have pure volunteers. These are people who have actually just volunteered their services for the service of their community. They receive no remuneration. And all these actually, in the end, you have to consider when you are actually looking at work can you expect from them and what are the outcomes you can get from them. Then, of course, their education was very varied, from class 3 to an A&M. So, you have to have a curriculum which is actually geared to all of them. It should not become uninteresting for the A&M, but the class third person should be able to understand that. And then, of course, there are other things like their experience and whether they live within their communities, because that is also a very important factor for an effective community health worker. Then we also looked at that we just found out from them what all do they do. Please remember again that these are not vertical standalone eye health workers, primary health workers. These are health workers who are already engaged in other things. This list is long. Not all of them are doing everything at the same time, but at least 5 of these, minimum 5 of these, they would be doing at one time. So essentially, we had these workers who already had a lot of other responsibilities. However, found the value of them in engaging with them because they were so embedded in their communities, and the community looked to them as people who connected them to healthcare. And that is why we thought that we would engage with them in our setting, which is actually a general healthcare setting. So next, what did we do? We looked at literature. So there is a lot of literature where primary eye care has been integrated with primary health care at the level of the primary eye care. This is mainly in Africa, in Pakistan, including they have trialed this with ASHA workers in India. And what was, similar from all literature was that, if they do feel the burden of another thing, though they are very excited and very happy with this new role. However, if you look at sustainability, it's going to be, it is difficult, especially if you put clinical examination and vision as a part of there. So if you train them to, maybe go house to house and check vision, it may happen for a few months or years when the project is on, but it's not sustainable. And most of them found that this was a burden to them. Some of them lost their skills. That is what was reported. Then some of them just, didn't do it because they found it difficult, or, there was cultural background to it. So we were not very keen to teach them clinical examination or a vision examination because of this literature and also from the feedback we got from them. So then we looked for an alternative method, and there was a WHO questionnaire which has been used to identify visual disability in field settings, and we revised that to use that. So I'm going to just come to that. But before that, looking at all this background and what did we actually want our health workers to do, we came up with 3 main competencies, which were around appropriate identification. This is the first. I'm not going to read this slide. I'm just going to give an example. Appropriate referral and effective communication for them to promote eye health. Then we looked at the learning objectives, which would be to demonstrate an appropriate level, for example, the first one. Then the assessment tools, I just want to show you how it is different for different things. So if it was just knowledge, MCQ, a pre-post objective test or a quiz is enough. However, if you're looking at their communication skills or their referral skills, then you need to do a workplace-based assessment, or you need to do an observed exercise like an OSCE with a checklist to see whether they are following everything. So this is just to show that you have a competency, you have several objectives in that, then you find your assessment tools, and then you go to your teaching learning methods, which are mainly interactive and based on adult learning. So like I said, we decided on a questionnaire-based model. And this was we define this was our little workbook which we designed. This was an in-house book, and these are the pictures of the questionnaire. The questionnaire on the left is in English. Of course the workers used it in Tamil, but essentially it is history based, about visual impairment, for near and far, for a person who can't, function, or a person whose eyes look different. We also added to it a pictorial tool where they could identify pathology looking at pictures. We also realized that there are pathology where there will be no visual loss. For example, diabetic retinopathy and glaucoma. And therefore, we added diabetic retinopathy, ensuring that diabetics were screened, as well as asking them to ask everyone over 40 to visit a vision center at least once. So these are just some, snapshots from the workbook. So we had sample pictures for them to identify, and even show it to families to see if someone in their home had that. So pediatric and adult cataract, corneal opacity, and of course we had all other pathology which is recognizable by the naked eye. This was for eye health promotion, again an in-house built local art tool, which we taught them using this about eye health promotion, and these were the same tools. So it was a flip chart, and we taught them using that, and then we gave each of them these so that they would then use it in the community to improve uh, knowledge about eye health promotion and prevention of injury, prevention of eye disease. These are just snapshots. It had a whole lot of uh, blinding and conditions which cause blindness and visual impairment. Um, the third competency was around referral, if you remember. So we designed this a referral guideline for them and they really like this tool. This was the most favorite part of their learning, where they were given the ability to actually decide when they could refer. So it was depending on the history. So you can see it's mainly pictorial, very little words, and we had an algorithm by which who they referred and when they referred. So an emergency would be referred the same day to the casualty. Uh, the yellow is a semi-urgent referral, like a child or people with blindness. And a green referral would be, it could be within 2 weeks to a month to either a vision center or a camp. Yeah, so these are just some pictures of the different types and ways in which you can engage with your learners. So going from the left top, this is just a discussion. We are having a discussion of how a normal eye looks and how important vision is. Then the next picture to the right is a small group around the table looking at pictures, discussing. Then the third picture is eye models, looking at normal and pathology. The lower two pictures on the right are actual clinical examinations by them of patients, just to make them interested in this. And the left bottom is a role play where they are actually conducting history and doing a health promotion exercise. This was another exercise we used. It was mainly like a context-based discussion. This was essentially for teaching them the value of vision, because remember, these were general healthcare workers. And so these were just trigger points. So you show them a picture and you trigger off a discussion and you describe what you're seeing in the picture and what all is happening. And then to think of how would it be for a person with visual impairment or blindness to actually do what people in these pictures are doing, and then just let them explore. And then they talked about it, they came up with examples in their neighborhood, in their families, and realizing that how important eye care was, and it was just as important as healthcare. This was another picture for discussion, like how would a patient with diabetes, say, look after their health if their vision was gone. So this again so you bring out the values and the attitudes from within them and they discuss it together. This was another way where we taught them, these were just, what are the barriers? Like, why don't people access eye care? And again, these were just areas where each of them discussed, and each of them also came up with ideas as to how they could help overcome these barriers. Yeah. So I wanted to ask people here now, can someone put in the chat box, or what what does this mean to you? What is this pyramid called? Or have you heard of this? Or what is this model?
You can type it, participants, you should be able to type it in the chat box now.
Great. Yeah. So we have some answers, and yes, that is the Kirkpatrick's model. And like I had said, that I think in the beginning of my slide, when we were talking about competency-based approach, that apart from just, you know, rendering your program, it is very, very important to have a program evaluation and have it embedded right from the beginning, because that actually feeds in to your training and helps it make it better, help you change things, help you find the lacunae or the gaps, and help you change things. So the first yeah. So the first, let's look at the first level, which is the reaction, which is essentially how what did the learners think about it? How was their experience knowing about that? So there are several ways to find out, get learner feedback. One is, of course, very simple thing which we all do, is just getting immediate post training feedback from the learners, and it could be objective, it could be subjective, depending on your learner. Then later on, we continued to do this because we wanted to know how they were functioning actually in the field. So we have done that with their monthly meetings. We have conducted focus groups and in-depth interviews. So while we did get very positive responses to the training, they really felt empowered, and felt that their, confidence in referral and educating communities had increased. Patients were actually seeking them out, and especially the ability to refer directly made them quite empowered. And there were several removal of their own misconceptions, which they had that helped them to then remove those misconceptions in their community as well. However, there were points which they brought up which were not so great, which was, again, their difficulties in time management. Because they are doing so many other things and so many other departments, sometimes there is confusion with other projects. And of course, they also gave us several suggestions for community education and further training. About the difficulties in time management and the confusion with other projects, we were able to at least put a few things into place. And of course, their suggestions for improvement of their training were great, which we have been, I'll come to that a little later. But just to say that both the good and the bad has to be taken, and we have to see what we can do about the things which may be negative. The second thing is the learning and the behavior. So I have kind of clubbed the two together, because learning itself is where you assess how much your learners have learned, and behavior is how has it changed their behavior in the field. So I have combined these two because there was a lot of workplace-based assessment, which also is a kind of behavior change. So I have clubbed these two together. So these are just assessments. So of course, the first table on top, we did the regular pre-tests, which, as you can see, it's not too bad. That was because they did have some pre-knowledge of ophthalmology, mainly related to cataracts, because that is so common, and diabetes, because they were already general healthcare workers. But there was a significant improvement. However, the long-term retention, as you can see, was kind of stable in the salaried workers, because these workers are quite well educated, and they are very able to read and keep up, while the volunteers and the paid projects are not. They don't have that advantage. So this showed us that we need to have more refreshers with them, and to continue retraining them in the field itself. Other things which we looked at was, every time a referral came in, we looked at the appropriateness of the referral, and we found that 94% were correct according to urgency. We also looked at diabetics being, how much did it improve, how much did the screening coverage increase after they started. On the right are some pictures of assessments. The picture on the top is an assessment which is happening in the classroom, which is like an observed exercise, like an OSCE, which we would do. We also had field-based assessments where we actually observed them. We also had field-based discussions, like we'd give them homework, they'd have to go to 5 families, do something, come back, and then we discuss with them, find their problems and try and rectify those. So these were examples of assessments for them, both knowledge as well as their service. We also, because we were not, obviously, because we had not used vision and clinical examination, we wanted to see how well this worked. And were we missing out patients with blindness and visual impairment? So our first was a pilot study where we just looked at the referrals that came to us, and we found that 97% of them were correct referrals. However, we had not examined the patients who never came to us. Therefore, we did a validity study where we looked at the sensitivity and specificity, comparing their work to history by an ophthalmologist and vision and examination by an ophthalmologist. And the sensitivity is quite respectable for a community field-based project. However, we did look to see that who were the patients who the ophthalmologists and optometrists picked up, and these community health workers didn't. And these were usually patients who were either presbyopes who did not want to wear glasses. I mean, they were doing well with, however, and patients who had mild to moderate visual impairment and who were in their day-to-day, vision was not affecting their activities of daily living. However, those with severe visual impairment and blindness, uh, all of them were referred. So that was at least a plus point, because yes, we could not check vision, but we also did not miss out people who actually needed eye care. And as the program has progressed, more and more community has become accepting to coming to vision centers, getting examined, especially in the tribal areas. So finally, results are what we look at as to how this whole program has actually changed, how it aligns with our organization, how it has changed, uh, the outcomes in our organization or in our program itself. And this is always the hardest to do. And we have not been really very successful in this. The ideal would be to look at blindness pre and post intervention, but these things have been kind of ongoing, piecemeal, area by area. Then, of course, other things like you all said, human resources, time, all that has also been. But we have looked at a few indices, and the things we have looked at is community perception, how it has changed. We have looked at, especially in the tribal hills, patients would not even, come even if we went there to get them. Now patients have started traveling by themselves to come to the institution. The numbers who are accessing care has increased. I'll show you the next slide. Referral uptake improvement, increasing in diabetes screening and coverage. We have also looked at the kind of patients that they have referred in, and the level of visual impairment and blindness in the patients that they have referred in, and their visual improvement. Looking at numbers, so the slide to the left, this was a comparative analysis between two areas, where we had the training and had the referral, and the other where there was regular service, which was just going on as usual. And these are integrated vision centers in the secondary care hospitals. So if you just look at the green and the purple line, so the arrow shows where the intervention happened, and of course there was a sudden rise in numbers. But then you go to purple, which is the next year. The whole of the next year, the average stayed above the regular average. So the numbers increased as compared to the right side, where, the average has kind of stayed same all across. There is a big dip in November in the purple, which is there in both. That was the time we had floods in Vellore. So that is why there was a less number. But generally, even after the intervention stopped, and the project stopped, the numbers continued to go on. So, what are the few specific concepts, challenges, and learnings from this? We talk about a learner-centered curriculum. I would like to put forward that when we are dealing with community health workers, people who work with their communities, who may always not be fully remunerated, um, who may not have be the best educated, we need to look at a learner context centered curriculum. That means look at their context, their demographics, their education, their roles, and then design your curriculum and your competencies. Then the cycle of training, supervision. Now, supervision is extremely important in the field. Also, looking at their numbers, looking at how accurate they are. This just happens as a part of your work-based assessment is extremely important. Getting feedback from them and giving feedback. So the next two, which is feedback and learning, is for both the health workers and for us as trainers. So the feedback we get from them helps us learn, and we also teach them back, and then we modify our training program and then retrain. Um, I talked about supervision already. The other learning point or the challenge which we had was our engagement with the other health specialities, their other supervisors, their departments. So we had to do a lot of advocacy and engagement with them for them to understand the importance of eye care. And so that is another thing which was a big learning point for us. Just to give you I talked about, the feedback and then us learning. So essentially, they gave us a feedback saying that we don't have a feedback loop. We refer the patient to you, but then we don't know what happened to the patient. And we did meet them in monthly meetings, but all we would do is give them numbers and say, oh, so many were referred, so many were not referred. So they also said that you all don't supervise us as much as the other specialties do. So we took that at their word, and then they said, we are fine. When you come for the monthly meetings, you can give a report card for us. How many patients came? How many did we refer? So we actually started doing that. And if you see the graph on the left, we had a real jump in the numbers where health workers, they were motivated because, and remember, these were volunteers. Now, LCCU over there is the low cost effective care unit, which is the urban health center, and they have unpaid volunteers. So they needed some different kind of motivation to actually improve their work. So these are just two snapshots from 2 months, just to show the kind of data we now go back to them with when we meet them. The other learning we had was under 5 pediatric training. We were very enthusiastic in the beginning. We thought that they could also, screen under 5 because that is such a neglected part of pediatric screening. And we did give them, we tried, fixing and tracking. We tried to make homemade Leah paddles and gave it to them, but somehow that never worked. And that, led us to remove that from a competency and change that to. So now we've changed to screening children in pediatric immunization clinics rather than burden the community health worker with the same. Yeah, so to wrap up, community health workers, general healthcare workers, which I talked about, it's engaging with them is essential for people-centered eye care. And for us, as we look towards universal eye care, we look towards integrated people eye care, I think we will need to start engaging also with community health workers who are in the general healthcare system. And when we do that, let us remember to have a learner context centered curriculum and always remember the loop of training, supervision, feedback, learning again, and retraining. So I want to thank all of you for your time. Again, thank Divya and LAICO for this opportunity. These are just pictures on the right of our small outreach team. And on the left, this is just a picture after one of the training sessions with our wonderful health workers who are so enthusiastic and so motivated and dedicated towards this work. Thank you so much.